welcome to the virtual APSA 2021 scientific session number 2, Education, Advocacy, DEI, and General Surgery. I'm one of your moderators, Dr. Erica Carlisle from the University of Iowa.
And I am Nicole Chandler from Johns Hopkins All Children's Hospital.
And I am Dr. Pam Choi from Naval Medical Center, San Diego.
So we're all members of your 2021 APSA Program Committee, and we're delighted to present the following posters and oral presentations. We have 6 posters that will run in succession without any video discussion, but you're welcome to ask questions in the chat function of the authors who are present today. After the posters have all run, Drs. Chandler, Choi, and I will present a short recap of what we felt were the highlights of those posters presented. Thereafter, we'll take on 8 abstracts in this session dedicated to education, advocacy, DEI, and general surgery. So without any further delay, here are the 2-minute poster presentations in our session.
Our first poster in the session will be presented by Jonathan Roach from Children's Hospital, Colorado, entitled The Pediatric Surgery Match from the Applicant Perspective.
Hello, and thank you for allowing us to present our study on the pediatric surgery match from the applicant perspective. The Pediatric Surgery Fellowship Match is a strenuous process used for training programs and applicants to evaluate and rank each other. While previous studies have evaluated applicant characteristics that may lead to a successful match into pediatric surgery, there are no data on what training program characteristics may be important to applicants. To evaluate this, we identified all applicants to our training program who were successful in matching into a pediatric surgery training program in the same cycle between 2018 and 2020. We created a 49-question survey that was sent electronically. Responses between 2 groups were compared. Of the 130 identified applicants, 63 participated by returning the survey for a 48% response rate. Selected responses are presented. The most important characteristics identified by applicants were index and neonatal case volume, as well as personal interactions with faculty and degree of autonomy. Unimportant characteristics included accommodations provided by the program on the interview day, trauma exposure, quantity of vacation time, and access to a simulation laboratory. When the group who matched into one of their top 3 ranked programs was compared to the group who matched into their 4th or lower ranked program, differences in institutional and faculty prestige, as well as support to attend national conferences, success of previous fellows, and advanced practice provider involvement were seen. In conclusion, this survey study shows index and neonatal case volume, interactions with faculty, and autonomy are the most important training program characteristics to applicants. The importance of other training program characteristics varied based on where on their rank list an applicant matched. Training programs may want to use these data to highlight their strengths in the pediatric surgery match process. Thank you again for the opportunity to present our work.
Our next poster in the session will be presented by Shreya Gupta from the University Hospitals Case Western Reserve University, entitled Is the Changing Landscape of Fellowship Recruitment During COVID-19 in Pediatric Surgery Fellowship Here to Stay?
Hello, my name is Shreya Gupta. Thank you for the invitation to present our work. Is the changing landscape of fellowship recruitment during COVID-19 in Pediatric Surgery Fellowship here to stay? COVID-19 forced upon us rapid change in the recruitment process, where most of the programs were caught in the mid-season to transition to virtual-only format, a format that had held potential but had never been accepted over the standard in-person interview. The purpose of this study was to evaluate the perception of virtual interviews by program directors and applicants. An online survey consisting of 28 and 44 questions were administered to the PDs and applicants in the US and Canada, respectively. Questions included, but not limited to, changes in the process, the platforms, format, comparison to the on-site interview, and overall satisfaction were included. Multiple variables were used for objective and subjective feedback. PD survey recorded a 95% participation rate. Majority of the programs changed their format to virtual and felt that that did not impact applicants' success and final rank list. They were overall satisfied. They did report lack of interpersonal interactions. 50% of the PDs preferred to have an on-site interview with virtual screening. Applicant survey had a lower participation rate, however, results were similar. 61% preferred an on-site interview. Applicants reported benefit in financial and time stress. In conclusion, COVID-19 led to a virtual season that was acceptable. However, a majority of PDs and applicants prefer a hybrid approach. This study should help guide future changes to optimize the interview experience for all in our near future. Thank you for listening.
Our next poster in this session will be presented by Edward Taggy from the Loma Linda University Children's Hospital, entitled Awareness of Both Positive and Negative Aspects of Parental Mental Health in a Level 4 NICU.
Hello, I'm Edward Taggy, Professor of Surgery, Pediatrics, and Behavioral Medicine, and I'm presenting our work on the awareness of both positive and negative aspects of parental mental health in a Level 4 NICU. Having an infant in a NICU is felt to be extremely stressful for a variety of reasons, and the parent's psychological makeup is important for their infant's eventual outcome. But there's little prospective data on the negative and positive aspects of parental mental health in the stressful NICU environment. So we created a questionnaire which included 7 validated psychological instruments. They looked at both negative mental health factors, such as depression and acute stress disorder, as well as positive mental health factors, such as psychological well-being and quality of life. 139 families took our questionnaire over several years. 70 of those families had an infant that was unplanned, and 95 of the infants were premature. For the negative mental health factors, 62 of the families endorsed clinical levels of depression, and 14 families met clinical criteria of acute stress disorder. Parents use emotion-focused coping much more significantly than problem-focused coping. On the positive side, when we looked at the quality of life, 88% of our families were in the average or high category. And in the psychological well-being scale, which measures 6 aspects of happiness, the majority of families endorse high scores in both purpose in life and personal growth, whilst the majority did endorse low scores in environmental mastery. So in summary, parents of NICU infants demonstrate significant stress, high levels of depression, and common acute stress disorder symptomatology. Surprisingly, parents also exhibit a number of psychological strengths, such as an unexpectedly high quality of life and psychological well-being. Pediatric surgeons should be aware of these complex parental mental health issues, which will help provide insight into the best way to intervene, which hopefully will benefit not only the parents, but potentially the infants. Thank you for the opportunity to present this data.
Our next poster in this session will be presented by Maria Bemis-George from Carolinas Medical Center, entitled Improving Satisfaction, Comprehension, and Apprehension in Pediatric Surgical Populations, the Use of Comprehensive Children's Books.
Surgery generates anxiety and stress, which have been shown to negatively impact postoperative outcomes and understanding of informed consent. We assessed whether educational, illustrated children's books improve comprehension, satisfaction, and anxiety of caregivers in pediatric surgical populations. A prospective randomized trial was initiated at a tertiary care children's hospital. All patients less than or equal to 18 years of age with a caregiver present and a diagnosis of uncomplicated appendicitis, ruptured appendicitis, pyloric stenosis, umbilical hernia, and a need for a gastrostomy tube were included. Conventional consent was obtained, followed by completion of a validated survey with 17 questions addressing apprehension, satisfaction, and comprehension. Randomization in a 2-to-1 manner occurred after consent and prior to operative intervention, with the experimental group receiving an illustrated comprehensive children's book outlining anatomy, pathophysiology, hospital course, and postoperative care. A second identical survey was completed prior to discharge. 80 caregivers were included, 55 in the experimental group. There were no significant differences in patient or caregiver demographics between groups. The baseline survey demonstrated no difference in comprehension, satisfaction, or apprehension between groups, all p-values non-significant. After intervention, the experiment group had significant improvement in 14 of the 17 questions compared to the control group, all p-values less than 0.05. When tabulated by content, there was significant improvement in comprehension, p equals 0.0009, satisfaction, p less than 0.001, and apprehension, p less than 0.001. Use of illustrated educational children's books to explain pathophysiology in surgical care may improve comprehension, satisfaction, and anxiety of caregivers. This could benefit informed consent, understanding, and post-operative outcomes.
Our next poster in this session will be presented by Mohanish Kumar from Beaumont Health, entitled The Evolving Effectiveness of Biologics in Avoiding Surgery in Children with Ulcerative Colitis.
Hello, my name is Mohanish Kumar, and I'm a general surgery resident at Beaumont Health in Royal Oak, Michigan. We'd like to thank APSA for giving us the opportunity to present our work. My topic is the evolving effectiveness of biologics and the decreased role of surgery in children with ulcerative colitis. As we know, there have been an increasing number of biologics available on the market, and the management of pediatric UC has become more complex. The purpose of this study was to assess the effectiveness of biologic agents in achieving remission and the incidence of surgery. We identified all patients with UC under the age of 18 that were seen in pediatric GI clinic. We divided the patients into 4 groups: those that were medically responsive, no biologics or 1 biologic, or medically refractory, patients on multiple biologics or surgery. In total, we identified 115 patients with UC. 42% of patients were treated without biologics or surgery. 29% of patients were treated with 1 biologic. 21% of patients required multiple biologics, and only 8% needed colectomy. Most patients, about 71%, had medically responsive disease, and 63% of these patients were symptom-free at last follow-up. 29% of patients had disease refractory to traditional medical therapy, which we defined as requiring multiple biologics or colectomy. The majority, about 72% of medically refractory patients, likely avoided surgery due to multiple biologics. Patients on multiple biologics had a 29% remission. In conclusion, new biologics are changing the landscape in maintaining remission from UC. And although 72% of medically refractory patients avoided surgery on multiple biologics, only 29% were living without symptoms on their 2nd, 3rd, or even 4th biologic. Thank you for listening, and please feel free to reach out to me with any questions.
Our final poster in this session will be presented by Derek Wakeman from the University of Rochester, entitled The Utility of Intraoperative Peritoneal Cultures During Appendectomy for Complicated Appendicitis.
Due to a high surgical site infection rate at our children's hospital, an interdisciplinary team embarked on a quality improvement project to reduce surgical site infections after appendectomy for complicated appendicitis. Further, we hypothesized that intraoperative culture of purulent fluid during appendectomy would allow us to better understand the microbiome contributing to appendicitis and improve antibiotic stewardship. We implemented a clinical practice guideline which standardized intra- and postoperative care for complicated appendicitis. This included obtaining an intraoperative culture during appendectomy. Children were treated with piperacillin tazobactam for at least 72 hours postoperatively. We tailored home antibiotics to the culture results. NSQIP reported outcomes were compared before and after implementation of the guideline. The mean number of days between surgical site infections after appendectomy for complicated appendicitis increased significantly from 27 to 60 days after guideline implementation. Surgical site infections decreased by 55% over the study. Based on our prior infection rate, 6 infections were prevented, though this reduction did not reach statistical significance in chi-square analysis. The number of ED visits, readmissions, and overall morbidity did decrease significantly. From culture data, we found that antibiotic resistance in E. coli was common, including to antibiotics commonly utilized for complicated appendicitis. Overall, the culture results changed home antibiotics prescribed at discharge for 13 children. In conclusion, we used a clinical practice guideline to standardize care and improve outcomes after appendectomy for complicated appendicitis. We believe intraoperative cultures can help tailor antibiotics for complicated appendicitis, particularly for organisms with antibiotic resistance. Based on the reductions in surgical site infections, emergency department visits, and readmissions, the project returned approximately $235,000 on investment in 1 year. My contact information and a QR code which will link to project content on the APSA Quality and Safety Toolkit is provided. Thank you.
Thank you for all the authors for these enlightening posters. The 3 of us would like to provide a brief synopsis of what we felt were the learning points we took away from these posters. The first poster to kick off this session was by Dr. Roach, who presented the pediatric surgery match from the applicant perspective. Dr. Roach and colleagues queried matched applicants from the 2018 through 2020 cycle. Applicants valued index and neonatal case volumes, interactions with faculty, and autonomy as highly desirable in a program. Less importance was placed on interview accommodations provided by the program, trauma exposure, quality of vacation time, and access to a simulation center. Those who matched into one of their top 3 choices placed less emphasis on the prestige of faculty and program, support to attend national conferences, success of previous fellows, and involvement of advanced practice providers. This is important information that programs can use to highlight the strengths that align with the applicant's interests during the application process. The second poster, titled "Is the Changing Landscape of Fellowship Recruitment During COVID-19 in Pediatric Surgery Fellowship Here to Stay?" This was presented by Dr. Gupta and described findings from a survey of program directors and applicants who transitioned to a virtual interview format during the COVID-19 pandemic. Program directors did not feel that the virtual interview format impacted applicant rank or success in the match and were overall satisfied with the virtual format. Program directors reported a lack of interpersonal interactions during the process. 50% of program directors would prefer to have on-site interviews with a virtual screening process. Applicants reported similar reports in their responses, with a 61% preferring an on-site interview. However, they reported an improvement in financial and time stress with the virtual format. The authors concluded that the majority of stakeholders prefer a hybrid approach to the interview process, and that this information can be used to help optimize the fellowship interview process in the future.
I really appreciated Dr. Taggi's presentation entitled "Awareness of Both Positive and Negative Aspects of Parental Mental Health in a Level 4 NICU." He highlighted that despite the elevated levels of stress and anxiety faced by parents of babies in the NICU, parents demonstrate high levels of psychological strength, such as quality of life, personal growth, and purpose in life. I also really valued Dr. Behemoth-George's presentation on the impact of children's books in improvement in satisfaction, comprehension, and apprehension preoperatively. And as I was considering my marks, I wondered if maybe combining forces to evaluate the impacts of children's books for NICU parents might be a neat next step. So perhaps we'll look forward to that talk next year. Thank you again for wonderful presentations.
Ulcerative colitis has always been a challenging disease. Dr. Kumar's abstract, "The Evolving Effectiveness of Biologics and Avoiding Surgery in Children with Ulcerative Colitis," is a retrospective review of all UC patients for the last 8 years. There were a total of 115 UC patients identified, and about half were on at least one or more biologic agent, with only 7.8% who required surgery. 29% of the cohort had medically refractory disease, which was defined as any patient who either received surgery or were on 2 or more biologic agents. In this group with medically refractory disease, 72% were on multiple biologics and were stated to have avoided surgery, but only 29% of this group were symptom-free. While biologics have certainly been a game changer, I wonder if this means that there should actually be a larger role for surgery to achieve symptom relief. Are there any patients who should just get surgery instead of being on multiple biologics? Thank you, Dr. Kumar, for this interesting presentation, and I look forward to reading the manuscript. And finally, do you take peritoneal cultures during complicated appendectomies? Admittedly, I don't, but according to Dr. Wakeman's presentation, maybe I should. At the University of Rochester, a clinical practice guideline for complicated appendicitis was implemented, which included obtaining a culture of intra-abdominal purulent fluid during surgery. Culture results changed the choice of antibiotics in 38% of patients. All-cause morbidity decreased significantly from 33% to about 10%, particularly in the number of ED visits and readmissions post-implementation. If you want to learn more, check out the QR code on the poster. Another excellent quality improvement initiative from Dr. Wakeman and the University of Rochester.
We'd now like to switch gears and hear from our scientific session presenters and their respective invited discussants. Each 4-minute presentation will be followed by a 4-minute interactive discussion between the author and a selected discussant. You're also invited to chime in with questions in the chat box that will be addressed by our presenting authors. There are 8 abstracts in this session dedicated to education, advocacy, DEI, and general surgery. Our first abstract in this session will be presented by Dr. Wendy Stefanoff from Children's Mercy Hospital. Her presentation is entitled, "Does Access to Care Influence a Child's Presentation with Appendicitis?"
Thank you for the opportunity to present our work. We have no disclosures. Disparities such as differences in racial backgrounds, socioeconomic levels, and places of residence can lead to increased mortality, increased complication rates, and longer lengths of stay in the hospital. In the pediatric population, these differences have been reported in the outcomes of patients undergoing cardiac surgery who are diagnosed with cancer and who present with traumatic injuries. The aim of this study was to identify disparities between race, socioeconomic status, and access to healthcare, and to determine if these disparities were associated with differences in the timing and severity of appendicitis at presentation. This was a single institution prospective study of children less than 18 years old who underwent laparoscopic appendectomy for either simple or complicated appendicitis from May of 2018 to February of 2021. Prior to discharge, caregivers were asked to complete a survey that focused on pediatric healthcare encounters within the previous year. The survey was based off of the United States National Health Interview Survey and included questions about accessing the medical system during times when the child was ill or well. The family experienced times when they were either denied care for their child or were unable to afford medications for their child. Clinical data acquired from the medical chart included demographics, preoperative workup, intraoperative characteristics, and postoperative outcomes. 243 patients were included. The median age at time of appendectomy for the cohort was 11 years old. 67% of respondents identified as Caucasian, 14% as Hispanic, 8% as African American, and 5% as multiracial. Significantly more Hispanic, African American, and multiracial patients had Medicaid insurance, and Hispanic and African American patients were more likely to come from more disadvantaged neighborhoods compared to their counterparts. The most common presenting symptom was abdominal pain in all groups, although Hispanic patients also more often presented with fever. There were no differences in preoperative imaging. Interestingly, while the duration of symptoms prior to presentation was similar between groups, a higher percentage of Hispanic patients presented to the ER multiple times prior to diagnosis. Significantly more Hispanic patients presented with perforated appendicitis compared to other racial groups. However, fewer Hispanic, African American, and multiracial patients with simple appendicitis were able to be discharged the same day of surgery. There was no difference in the percentage of patients who returned to the emergency room following initial discharge. Survey results reveal that significantly more Hispanic caregivers reported having trouble finding a general provider, and both Hispanic and African Americans noted having difficulty affording medications for their child. More Hispanic, African American, and multiracial caregivers stated that their child had visited a pediatric ER 2 or more times in the past year, which was significantly higher than their counterparts. Hispanic and African Americans were more likely to go to a pediatric emergency room when their child was ill compared to other ethnicities who preferentially visited a doctor's office. Likewise, while all patients most commonly visited a doctor's office for preventative care, a higher percentage of minorities also responded that they used a clinic or health center compared to Caucasian respondents. A subgroup analysis was then performed looking at the 85 patients who presented with perforated appendicitis. Hispanic, African American, and multiracial patients were more likely to have Medicaid insurance, and all minority groups were more likely to have been seen in the ER more than once for their symptoms prior to appendicitis diagnosis. Similar to the general results, of those with perforated appendicitis, more Hispanic, African American, and multiracial caregivers stated they utilized a pediatric ER when their child was ill, compared to other racial groups who preferentially utilized a doctor's office. And these same groups more often accessed an urgent care or clinic for routine or preventative care. While there was no difference in the ability to find a general provider or to afford medications, more Hispanic and African American caregivers stated that they had utilized a pediatric ER 2 or more times in the past year. In conclusion, a greater percentage of Hispanic and African American patients utilized the ER multiple times in the year before being diagnosed with appendicitis, including being seen in the ER more than once for their appendicitis symptoms. Further studies are needed to help mitigate these missed opportunities and improve efficient healthcare utilization. Thank you, and I'd be happy to answer any questions.
Thank you, Dr. Stefanoff. The invited discussant for this paper is Dr. Mehul Raval from Lurie Children's Hospital.
First off, congratulations on this important contribution. Within the healthcare world, we have long spoken about shifting our focus from volume to value. This has been a slow but steady shift that includes being thoughtful about our patients and their families in terms of what happens to them outside the walls of our operating rooms and our hospitals. Your study highlights that there are factors that may influence surgical outcomes for something as common as appendicitis, such as race, ethnicity, and other socioeconomic factors like neighborhood income. Specifically, African Americans and Hispanic patients appear to utilize the ER more often than white patients, both prior to their appendectomy and during the workup of their appendicitis care. This highlights that we absolutely need to view healthcare with a more holistic lens to provide our patients with the most comprehensive and highest quality care. So I have two questions. My first question is that based on your work and review of this literature, what are the tangible ways that we, as pediatric surgeons, can do to facilitate improved access to care. Second, your data showed that access to postoperative care did not have the same observed disparity. I would expect that if families were used to utilizing the ER for care prior to surgery, the same would be observed in the postoperative phase of care, with visits to the ER for minor things like wound issues or pain control. Why do you think that was not the case in your data?
Well, thank you very much for these questions. Looking at the first question, the study was actually an extension of another study we did, which showed that while Hispanic patients had higher rates of perforated appendicitis, their postoperative length of stay was similar to their Caucasian and African American counterparts. We attributed this similarity to the utilization of patient-driven postoperative management protocols, concluding that standardizing care for all patients with perforated appendicitis mitigates some of the disparities that may potentially exist during the hospital stay. For the preoperative care highlighted in this study, there definitely needs to be better understanding of what happens in the emergency department when minorities present. It is possible that the symptoms, examination, and workup need to be better scrutinized to ensure that we're not missing these diagnoses. This is not an incrimination of the emergency physicians or even surgical providers, but we cannot deny that these differences do exist. There is likewise a need to provide additional education to our minority communities on these symptoms to encourage early presentation to our healthcare system. Regarding your second question, for our families that come to us with appendicitis, in the discharge instruction packet that they receive, the general surgery triage phone number is included, and patients' families are encouraged to use that number at all times with questions that they may have. So minor wound concerns or pain management issues may initially come through this triage line and are addressed without the need for families to come to the emergency room. These calls were not part of the data captured for this project, but may reflect why disparities were not identified in postoperative ER utilization. While we take care of many pediatric patients that live hours away from our institution, they may have visited their local ER for minor concerns, which we were also not able to capture. However, we think this is unlikely based on our past experience. We also believe that our postoperative algorithms for appendicitis have been well defined over time, and this has also helped to mitigate any potential disparities that you might see after surgery. Thank you.
Thank you, Drs. Stefanoff and Ruval.
Our next abstract in this session will be presented by Danielle Walsh from East Carolina University. Her presentation is entitled, "Good Wishes Aren't Enough, Disparity in Surgical Outcomes Despite Institutional Mission."
Thank you for the opportunity to share our work on institutional mission and surgical disparities in pediatric care. Institutional missions have been shown to have an influence on outcomes in healthcare, and the mission of our institution is to care for a rural population, as well as to enhance access of minority students to medical education. Our population is largely impoverished with a very low income, and approximately 75% of our patients are either on Medicaid or CHIP for coverage. We have a high minority population and a very rural focus, and we wanted to know how this impacts pediatric surgical outcomes. We were motivated to look into this based on a report in Pediatrics where they looked at ASA 1 and 2 healthy patients and found that African American patients had 3.43 the odds of death postoperatively, and they were unsure of the causality of it. So we assessed whether our institutional focus on a disparate rural population improved outcomes for African Americans over the national reporting. Stepwise, we first needed to validate the pediatric surgery risk calculator in our institution. We applied that risk calculator to each patient. We then compared that to actual individual patient outcomes, identified any differences by race, tried to ascertain any preoperative risk factors contributing to that, and compared to national reporting. We assessed over 2,650 patients over 3 years and found that while ASA 2 classes were equal between the races, more ASA 1 patients were white and more ASA 3, 4, and 5 patients were African American. We then validated the risk calculator and found it was extremely accurate despite the differences in our population, with only two small areas of difference. First, we had no white patients with renal failure postoperatively, and secondly, we did find a higher and less accurate concordance in unplanned reintubations in African Americans. But all of the other factors correlated well. We then compared that to actual outcomes and found that overall mortality for all ASA classes was 2.98 times higher for Black patients as compared to white patients. And we also found a slightly higher complication rate for all ASA patients, exclusive of mortality. Sub-analysis of those complications found actually that only pneumonia was statistically significant. We then reviewed our statistics compared to the national data and found that we had no deaths in the ASA 1 and 2 patients, making the odds for Black and white patients equal in our population. We did, however, still have a slightly increased risk of morbidity in Black patients as compared to white. So while we overall did better, we still have some imperfections and opportunities to improve. For 2/3 of the complications could be predicted by the risk calculator. The surgical site infection rate, the intraoperative component, was largely equal, despite African Americans being predicted to have more surgical site infections. And so we feel that the preoperative health status is really the strongest contributor to complications. In summary, the pediatric surgery risk calculator is accurate in predicting complications in a rural, underserved population. Unfortunately, African American patients are still more likely to experience complications and mortality than their white peers for all risk categories, but this difference nearly resolves for the lowest risk ASA 1 and 2 patients. We feel the increased risk correlates largely with their preoperative comorbidity, creating opportunity for targeted health intervention, and that our dedicated institutional mission may improve surgical outcomes in African American children. Thank you for your time and attention.
Thank you, Dr. Walsh. The invited discussant for this paper is Dr. Raquel Gonzalez from Johns Hopkins All Children's Hospital.
We have a very important presentation of a very important aspect, right, in healthcare. And so one of my questions was, what are your thoughts pertaining to that lack of concordance of the risk calculator in the unplanned reintubations with the African-American patients? And is there an opportunity for improvement with this?
Sure. Well, when you're looking at the reintubation concordance, that was us trying to validate the risk calculator. And so that was both the African-American and the white patients in there. So it's all across that. And when we started, when that turned up as discordant, I started trying to look back at those individual charts. And fortunately, NSQIP lets you do that. And in doing so, I discovered a few things. First, most of the patients in that group who required reintubation had multiple procedures. And the risk calculator really has you put in the main CPT code. So some of it may be that those patients are more complicated than the risk calculator accounts for. And then the second trend that I found in that group was really interesting because it was different units. So when I separated out by age and looked at those populations, what I found is that our neonatal population had a very low reintubation rate, and our older child population going to a separate ICU had a much higher rate. And it turns out in that period of time, that unit was less aggressive about using non-invasive methods before reintubating a patient. So I think between those two factors, that's why it wasn't as concordant. But even so, it gave us important information of where opportunities to improve in our institution were.
Awesome, awesome, thank you. And now that you have this information about the mission and your statement and what's driving the institution, what are you going to do with this information? Will you adjust or evolve your mission statement to target the African-American population and mostly the ASA 3 and more, right? Because you didn't see a difference between ASA class 1 and 2.
Correct. So I think that there's a couple components to that. So the mission statement is right. We're just failing to meet it in all of our populations. So that onus is on us to really meet it. And I think that I've really benefited from a lot of the literature that's come out in this recent year about how we can further lower implicit bias and make sure that these patients have the best opportunity to do well. So simple things like how they're listed in the chart, making sure that we bring the parents in and have very thorough conversations about what operation we're planning, what operation could be done as an alternative, and what non-surgical treatments could be done. So really engaging the families a little bit more. I think that while our surgical department has gone through implicit bias training, not everyone in the institution has. And I think that the conversations that have occurred in 2020 and early 2021 have opened the door for us to really help educate everyone else around us and make them sensitive to the needs of this unique population. I think a lot of it comes down to baseline medical problems that we don't always spend enough time optimizing in advance. So we know they have sickle cell disease. We know they have bad asthma. I mean, we know that they have renal failure. How much effort did we put into addressing those factors before we put them through an operation? Was it just an acknowledgement that it was there and a cognizant, or did we try and make sure they were as healthy as they could be? And that's what we need to work on next.
Awesome, awesome. Great points. Thanks for clarifying again. Keep up the good work because this is very important.
Well, thanks for your questions.
Thank you, Drs. Walsh and Gonzalez.
Our next abstract in this session will be presented by Samuel Rice Townsend from Seattle Children's Hospital. His presentation is entitled Fecal Continence, Disparities in Patients with Anal Rectal Malformations Treated at Referral Institutions for Pediatric Colorectal Surgery.
Thank you for this opportunity to present our work. Fecal incontinence is a problem for many patients born with an anorectal malformation, or ARM, that can significantly impact quality of life. Racial, ethnic, and socioeconomic disparities have been demonstrated in many areas of pediatric healthcare, but it is unknown whether such disparities affect fecal continence in children with ARM. This study's primary objective was to evaluate overall fecal continence rates in patients with ARM, utilizing a multi-institutional cohort, and to evaluate for racial, ethnic, and socioeconomic differences. Information was collected via the Pediatric Colorectal and Pelvic Learning Consortium, or PCPLC. The PCPLC is a coordinated multi-center research consortium of pediatric colorectal and pelvic reconstructive specialty centers organized to improve care through standardization of definitions, quality improvement efforts, and multi-center research. Completeness and validity are monitored by a data coordinating center. Patients 3 years and older with ARM presenting at a PCPLC institution from 2016 until 2020 were included. Continence was assessed at the patient's first visit in the registry after the age of 3. Fecal continence was defined as being free of stool accidents. ARM complexity was categorized by diagnosis. The associations of fecal continence with patient demographics and disease characteristics were assessed using trend tests and a multivariable logistic regression model. A total of 509 patients with ARM were included in the study at 11 centers. The majority of the patients in this cohort were male, white, and non-Hispanic. The majority of the patients also had private insurance. ARM complexity was relatively evenly distributed between the cohort of patients. The majority had no spine abnormalities and normal sacrum and had no complications reported after the initial surgical intervention. 24% of all patients included reported complete fecal continence or had no accidents. Daytime fecal continence was defined as occasional accidents during night only. Partial fecal continence was defined as occasional accidents both day or night. Fecal continence was more common in older patients. Type of insurance coverage also appeared to correlate with fecal continence. Patients with mixed payer status of both public and private insurance were seen to have decreased continence. And increasing ARM complexity showed a relationship with decreased continence approaching statistical significance. Sex, race, ethnicity, spine, and sacrum were not seen to be associated with fecal continence. When adjusting for clinical factors with a multivariable logistic regression model, only age showed a statistical association. ARM complexity again trended towards statistical significance. Spine, sacrum, type of insurance coverage, ethnicity, and race did not show any increased odds or relationship to increased fecal incontinence in this multivariable analysis. The study does have limitations. Coding errors may exist. An assessment of continence was made for individual patients based on a single encounter, and for some patients, this may not represent the true state of their continence. As PCPLC centers are located regionally with travel often required for evaluation, this may select a patient population with more means and greater access to regional care. Lastly, our patient group was heterogeneous, and this may limit interpretation of some findings. This is the first multi-center study to report fecal continence rates in a large cohort of children with ARM and specifically evaluate for racial, ethnic, and socioeconomic disparities. Fecal continence rates in this patient population were seen to be dependent on age only. There was a trend towards significance for patients with more complex malformations having lower rates of continence. Race and ethnic status were not associated with differences in fecal continence rates. In our study, we did find an initial association between insurance status and level of continence, but this was not significantly associated, controlling for other variables. Thank you to all the PCPLC institutions for their collaboration, and thank you very much for your attention.
Thank you, Dr. Rice-Townsend. The invited discussant for this paper is Dr. Don Lucas from Navy Medical Center, San Diego.
Hello, my name is Don Lucas, and I'm joining you from sunny San Diego. I'd like to thank Dr. Rice-Townsend and the PCPLC for this important work. As a field, it is critical to undergo this type of self-examination and work towards equity of outcomes for all of our patients in pediatric surgery. Furthermore, as a NISQUIT pediatric surgeon champion, I am very aware of the limitations of short-term outcomes, and I applaud your group for looking at long-term functional results, which are often more important but much harder to study than perioperative complications. While it is reassuring that you did not find disparities in outcomes by race, ethnicity, or insurance status within the consortium, I do have some questions for you about the study design and its implications. First, it is interesting that on univariate analysis of insurance coverage, patients with either public or private insurance had pretty similar results in terms of continence, while patients with both public and private insurance had markedly worse outcomes. Can you clarify who this group represents and why they might have worse outcomes? And secondly, while it is reassuring that patients with access to care in the consortium did not have significant outcomes disparities, I wonder about the patients you aren't seeing. For example, over 5% of children in the United States have no insurance, but none of the patients in your study were uninsured. While I would think and hope that every child born with an obstructive anorectal malformation in the United States would get at least a colostomy, I can imagine how difficult it would be to access bowel management or revisional surgery, and particularly regional referral without financial resources. Do you have any sense about what happens to these children or how you could study them? Thank you.
Thank you, Dr. Lucas. As to the first question, I agree it's an interesting finding, and we puzzled over this group and its worse outcomes across the board. I guess if there's something unique about this patient group that would portend worse outcomes, I'm not sure I could tell you what it is. We used, of course, insurance status as a marker for socioeconomic status. And so the real comparison here that we're interested in is between public and private. And we did not see a difference between the groups of public and private in terms of the fecal continence outcomes. Both of those groups were considerably larger, and so that may be part of the answer. I think ultimately, when we carried this out to a multivariable analysis, it's important to note that we did not see insurance status stand out as a predictor for worse outcomes. And then to your second question, thank you. We certainly wonder about this as well. One of the benefits of the consortium data set is that we can ask questions about this patient population that get at a level of granularity and outpatient follow-up that is difficult to capture in other multi-institutional data sets. Of course, at the same time, the patients and families seen at these referral institutions may not be representative of the national patient population. They may be more complex, they may be struggling more, but at the same time, they have the means to travel to one of these referral centers by one way or another. And so there's a little bit of an inherent bias there that's hard to get around. One possible way to study that within the consortium itself is to limit the analysis of this study or a future study, or do a subset analysis of those patients who are truly local to those institutions to try to take away some of that bias of patients traveling. I think, it's important to note, as I think you are suggesting, that just because we didn't see disparities related to race, ethnic status, socioeconomic status in this study doesn't mean that they don't exist on a national patient level, and certainly it warrants further study.
Thank you, Dr. Rice-Townsend and Dr. Lucas.
Our next abstract in this session will be presented by Dr. Eric Arungu from Kijabi Hospital. His presentation is entitled Management of Differences in Sexual Development, the Evolution of a Pragmatic Approach for a Resource-Limited Setting.
We are grateful for the opportunity to present our work. We have no disclosures. Management of patients with DSD is a challenge worldwide. Comprehensive care remains complex and resource-intense, making care more challenging in low and middle-income countries. Kijabi Hospital is a rural tertiary referral hospital in Kenya. In the present study, our objective was to categorize DSD cases, describe the evolution of care over time, and to present a pragmatic approach to management in a resource-limited setting. We performed a retrospective review of all patients who presented between 2005 and 2018 with a clinical finding of ambiguous genitalia or a diagnosis of DSD by histology of gonadal biopsy. 44 patients were identified. All patients had an assigned gender at the time of presentation, the majority being male. The median age at presentation was 6.5 years, and ovotesticular DSD was the most common diagnosis, with congenital adrenal hyperplasia a distant second, in contrast to most reports from high-income countries. Optimal management of patients with DSD is an interplay of multiple factors. In our setting, key drivers were noted to be the availability and cost of human resources, diagnostic services, and therapeutic interventions. In Kenya, most patients rely on the National Health Insurance Fund to access healthcare. Funding for NHIF increased over the study period. However, the insurance fund is highly weighted towards inpatient costs and surgical procedures. There is limited to no coverage of the specialized diagnostic studies needed for a comprehensive DSD diagnosis. In our cohort, the patients either paid out of pocket or were beneficiaries of limited research grants and donations. Thus, none of our patients were able to undergo a complete diagnostic workup. In view of this, there has been a heavy reliance on diagnostic surgical procedures and histology of gonadal biopsies to aid in diagnosis. Availability of pathology services in-house has made gonadal biopsies a mainstay in the workup. Minimally invasive diagnostic procedures have gradually replaced ultrasound and MRI that may be unreliable or financially inaccessible. Despite biochemical tests, hormonal assays, and genetics testing being available gradually in country over the study period, their high cost has remained prohibitive. Approach to care has evolved to include a multidisciplinary team. Active capacity building of team members has been evident, leading to provision of sustainable care. Visiting pediatric urologists have been pivotal in training in-house pediatric surgeons to provide necessary surgical services independently. Furthermore, a team of nurses and social workers, together with the surgeons and endocrinologists, have been incorporated to provide contextually appropriate psychosexual and psychosocial support. In addition, the pediatric urologist has improved patient evaluation and incorporated highly selective targeted testing as a cost-saving measure to aid in diagnosis. However, patient support groups are yet to be established. With this evolution of care into a multidisciplinary approach, the trend has been towards delaying reconstructive procedures until the child is of age to participate in a shared decision-making process. In conclusion, we present a pragmatic approach to the care of DSD patients in a low-resource setting that incorporates a contextually appropriate multidisciplinary approach with a trend towards precision diagnosis and holistic individualized care tailored to each patient. Thank you.
Thank you, Dr. Arungu. The invited discussant for this paper is Dr. Tamara Fitzgerald from Duke University.
Congratulations, Dr. Arungu and at Kajabi. This is a challenging problem in any setting. I think it's so impressive how Kajabi has taken the lead with this issue. And I know that this represents years of work. So I just wanted to congratulate you. My first question is, can you speak more about the importance of the visiting urologist and how often they were coming, and when they come? For you as a trainee, what was important in that interaction?
Thank you very much for your question. Visiting pediatric urologists have been key in the setting up and development of the DSD care teams. Previously, they will provide healthcare as a point-in-time service, whereby different surgeons will visit at different points in time as they will be available. And for this, most will be single visits. With this model, there has been a transfer of knowledge, especially regarding how to approach a child with DSD, decision-making processes on how to investigate the patient, how to manage when to operate. But more so, the highest impact has been in the transfer of skills, especially the surgical skills and techniques on how to do the different types of genitoplasties. However, with time, we think that the role has evolved with longevity in mind, meaning there is a need for surgeons who are willing to partner with us to allow for more regular visits, say once or twice every year. We think that this may be more sustainable. We think that it will provide some form of consistency of care with the patients as they will be able to interact with familiar faces. And we think this will allow for continuity of care. As you can imagine, these are very sensitive matters to the patients.
My second question was, do you have a formal multidisciplinary conference, or is this more of an informal process?
That's a very good question. Yes and no. Yes, meaning that there is a specialized DSD clinic that happens once a month. Patients are seen by the pediatric surgeon and the pediatric endocrinologist together in the same office. And during this time, the patients are evaluated, counseling is done, and there is formulation of a care plan. So this is done by the two subspecialty doctors together. However, no, meaning that there is no formal setup. We don't have a DSD care center. We don't have patient support groups. And the doctors and the clinic nurses usually double up as counselors and psychologists. And we often refer patients out of our hospital to clinical psychologists who can be able to help us with that, but we don't have one in-house who can be able to help us. So,
and my third question is, what will be your next steps in caring for these patients? If you had any resource available, what would you want the next resource to be?
That is an excellent question. I think in the short term, diagnostic laparoscopy being still one of the key steps in our diagnostic process needs some development, needs some assistance in building up our capacity for laparoscopy in general. It will be very helpful in the short term, especially in scaling up our operating equipment and even getting some training equipment. And this will also be able to help us as fellows and residents to be able to learn this very crucial step that is needed in making a diagnosis in our setup. However, in the long term, and this is more urgent, is in setting up a local regional genetic testing center. So in our country, there are several private laboratories that are able to offer these services. However, most of these samples are normally sent abroad to India, South Africa, Germany, and different other countries. And often we receive results that are incongruent to the patient's clinical picture. Now, this usually creates a problem because we cannot call or talk to the people who do the tests. We can't call them directly, so we can't be able to discuss with them. And we also, we can't send the patients back to redo the test because it's quite expensive for them to even do it in the first place. So this will really be able to help us in making definitive diagnosis for our patients. And also the other long-term thing will be setting up formal exchange programs with practical experiences in holistic DSD care.
Thank you, Dr. Zurungu and Dr. Fitzgerald.
Our next abstract in this session will be presented by Megan Bouchard from Lurie Children's Hospital of Chicago. Her presentation is entitled Utilization Trends and Disparities in Adolescent Bariatric Surgery in the U.S. 2006 to 2016.
Hi, my name is Megan Bouchard, and I thank you for the opportunity to present our work on utilization trends and disparities in adolescent bariatric surgery. We have no disclosures. Childhood obesity remains a significant concern in the United States, with an estimated increase from 13.9% to 18.5% over the past 2 decades. Amongst adolescents specifically, the prevalence of obesity is 20.6%. Vulnerable patient populations, including those of ethno-racial minority, public insurance, or low-income households, have disproportionately higher rates of obesity. However, there is no observed difference between boys and girls. And finally, there are higher rates of obesity in the South and the Midwest. Despite significant evidence of adolescent bariatric surgery's cost-effectiveness, safety, and support from medical societies, there is historically significant underutilization, particularly among vulnerable patient populations. There has been no trends analysis of adolescent bariatric surgery since 2009, where Keller and colleagues demonstrated a plateau in utilization from 2000 to 2009. Nevertheless, the last decade has seen an increase in adolescent bariatric centers and providers, new surgical techniques with the adoption of the sleeve gastrectomy, and further advocacy efforts to improve access. Therefore, we aim to describe overall national utilization trends in adolescent bariatric surgery and to investigate previously described sex, ethno-racial minority, income, and insurance-based disparities. We conducted a retrospective cross-sectional analysis of adolescents with severe obesity aged 10 to 19 years old who underwent initial bariatric surgery between 2009 to 2016 using HCUP's KID Inpatient Database, which is produced every 3 years. Utilizing codes from previously published studies, outcomes included the annual overall rate of adolescent bariatric surgery by the number of adolescents nationally, the number of adolescents with severe obesity nationally, and the number of inpatient adolescents with severe obesity from KID. We also assessed the type of bariatric procedure performed by year. A trend analysis was conducted, and then rates of bariatric surgery were stratified by year for various demographics and hospital characteristics. The number of initial adolescent bariatric surgeries performed increased from 707 in 2009 to 1205 in 2016. There were no significant changes in age or sex distribution of those undergoing bariatric surgery. Over time, bariatric surgery was increasingly performed at urban teaching hospitals, shifting away from urban non-teaching hospitals. And finally, both the Northeast and the South trended toward an increase in their proportion of bariatric procedures performed. However, while the Midwest remained relatively stable, the West actually significantly decreased. Among vulnerable patient populations, Hispanics and Blacks trended toward an increased rate of bariatric surgery, while publicly insured patients saw a significant increase in the rate of bariatric surgery. However, there was no significant difference in rates of bariatric surgery based on median household income over the study period. Over the study period, gastric bypass and gastric band significantly decreased, while the sleeve gastrectomy became the predominant type of bariatric surgery performed in adolescents. No matter the denominator, the rates of bariatric surgery per X population of US adolescents increased. Amongst inpatient obese adolescents included in KID, there was an increase in bariatric surgery rates from 1.89 in 2009 to 2.56 in 2016. Therefore, we concluded that bariatric surgery utilization has increased, though remains inadequate to address the growing prevalence of adolescent severe obesity. Additionally, while incremental improvements have been made in some disparities, many still persist based on age, sex, race, ethnicity, insurance, household income, and geography. Professional societies, including APSA, continue to call for improved equity and increased acceptance of and advocacy for access to bariatric surgery. While public health efforts are needed to reduce the incidence and prevalence of severe childhood obesity, in the meantime, further efforts are urgently needed to address disparities, reduce barriers to care, and ensure equitable access to surgery when needed. Thank you, and I'd be happy to take any questions.
Thank you, Dr. Bouchard. The invited discussant for this paper is Dr. Jose Greenspan from Cardinal Glennon Children's Hospital.
Thank you very much, Dr. Bouchard. So my first question is, obesity and access to resources falls into what I consider social determinants of health, or really not just me, but people who take care of children battling obesity. And your presentation recapitulates that pretty well. Can you comment on some ways that we could increase access to the underprivileged population in the next decade?
Thanks for the great question. Increasing access over the next decade will require multidisciplinary response, as we all know. First, other researchers have actually demonstrated that many providers are reluctant to refer patients for bariatric surgery, seeing it as a rather extreme solution to addressing adolescent obesity. And it's currently unknown whether these providers are concentrated in specific disciplines or regions, but nevertheless, provider education will be very important to improve access to surgeons. Furthermore, some qualitative studies have demonstrated that patients still see bariatric surgery as a last resort or quote unquote easy way out, or have even seen poor outcomes within their own communities for those who have undergone surgery before. And unfortunately, it's particularly amongst the underserved populations. So whether it's through local community or individual research, there's a great need for patient education on the high safety profile and efficacy of bariatric surgery to decrease the stigma with these procedures. And then other important measures will include maximizing insurance authorization for procedures across plans and state Medicaid and CHIP programs. And then also, in addition to increasing the number of bariatric providers, it's going to be important to continue strengthening referral networks from community clinics and hospitals to bariatric centers to minimize some of the geographic disparities. And then, of course, public health interventions to address the growing prevalence of adolescent obesity upstream will help to decrease the overall need for surgery. So.
Sure. Great answer. My second question is, do you think that the elimination of age as a determinant for candidacy for pediatric or adolescent bariatric surgery is going to help increase the utilization rate of bariatric surgery over the next 5 to 10 years in younger patients? Because previously we used to have a low cutoff age. Many places would have an institutional cutoff age to do the operation, but the consensus statement by all the organizations has taken age as a determinant away. So you think that that's going to be helpful?
Well, based on historic trends, as you know, referrals tend to primarily be in the 18 to 19-year-olds, despite it having been previously approved for some of the younger adolescents. It's unclear exactly why this is. It might be due to provider concerns of referring too early and committing the patient to surgery, or lack of family and patient buy-in. So perhaps the utilization rate will now increase for younger patients at hospitals that have adolescent bariatric centers, where providers may be more familiar with both the procedure and the current recommendations to remove those age restrictions, and so then potentially consider referring the patient sooner. But these referring providers will also be really crucial to addressing those patient and family concerns and decreasing the stigma associated with the procedure. I think in particular in a younger population, the stigma will be even higher. So in areas where there's less familiarity with the procedure, I think that removing the age restriction may not have a significant effect on utilization rates, at least initially, but hopefully with more time and more patient education and destigmatization efforts, I think age restriction for surgical candidacy will overall increase utilization rates in the long run.
Right. Now I can tell you my own opinion is that I think age is going to eventually, maybe not initially, but it is going to have an effect on referral, because the real criteria for surgery is going to be a medical complication of obesity. So it doesn't matter when the child becomes diabetic. If they're 9 and have a hemoglobin A1C of 10, that patient, if they have a BMI greater than 35, is now a candidate for the operation. Typically the BMIs trend much higher in children. It's not going to be a BMI of 35, it's going to be a BMI of 50. Mm-hmm. The other thing is the most recent publication from Team Labs about the overall efficacy of the operation in the kids versus adults. The operation is a much more effective operation with more durability when you look at the kids who have the operation than adults. I think that those two specific factors, if we're able to publicize those facts really widely, I think that that's going to help make obesity surgery less stigmatized in the future.
Absolutely. Well, thank you for the question.
Thank you, Dr. Bouchard and Dr. Greenspan. Dr. Bouchard, at the time of this recording, also just had her first baby, Charlotte Grace Bouchard, who weighed 7 pounds, 15 ounces, and is 21 inches long. On behalf of APSA, congratulations on this tremendous occasion, one of the few things better than an APSA presentation.
Our next abstract in this session will be presented by Dr. Roxanne Masumi from the University of California, Los Angeles. Her presentation is entitled Conflicts in Sharing Current Procedural Terminology Codes Between Adult and Pediatric Patients.
Thank you for the opportunity to present at the virtual APSA conference. We have no disclosures. The Relative Value Unit, or RVU, was introduced by the Centers for Medicare and Medicaid Services to help standardize the high variability and subjectivity in the physician reimbursement process. Although the RVU system was primarily developed for use in the elderly population, it is also used by private insurers and thus pediatric surgeons as well. The RVU consists of 3 main components: the work RVU, as well as practice and malpractice expenses. Each RVU is valued at a certain dollar amount. Common Procedural Terminology Codes, or CPT codes, are codes used to designate different operations or procedures. In order to determine repayment for a given procedure, each CPT code is assigned a number of RVUs meant to reflect the physician effort and time in performing the procedure. Many CPT codes are shared between adult and pediatric patients, despite the fact that a majority of these operations are often technically very different between the two populations. They are still given the same RVU valuations. For example, the CPT code and RVU valuation for a laparoscopic Nissen fundoplication is the same between adult and pediatrics, even though these can be very different operations. The primary drivers of RVU evaluations are operative time and length of stay. We thus hypothesize that these primary drivers, namely operative time and length of stay, in calculating RVUs for shared CPT codes will significantly vary between adults and children. Using the ACGME case log system, we identified common pediatric surgery procedures and then used Medicare data to identify which of these procedures are commonly performed in adults. We then used the National Surgical Quality Improvement Program, or NSQIP, to gather operative times and length of hospital stay for each of these codes. The codes without data available in the NSQIP database were excluded. Non-parametric comparisons of the median using rank sum tests were performed, and a p less than 0.05 was considered significant. We identified 11 indexed pediatric CPT codes covering a variety of different adult and pediatric surgery procedures, as listed here for your reference. Overall, about 46% of the operations had equal operative times. General surgeons had longer operative times in 18% of these CPT codes, and pediatric surgeons in 36%. Length of stay was the same in 27% of shared CPT codes. Both general surgeons and pediatric surgeons were each responsible for longer length of stay in 36% of these CPT codes. Even just among the 11 procedures that we examined in our study, the majority varied in their operative times and length of stay between adults and children. There are likely also many more procedures that we did not evaluate that vary in these key components that determine physician reimbursement. Thus, these findings support separating codes between adults and children in order to improve billing accuracy. Thank you very much for your time and attention. Thank you especially to Dr. Childers and Dr. Lee for your support and guidance in this project. Listed is my contact information. Please feel free to contact me with any questions.
Thank you, Dr. Masumi. The invited discussant for this paper is Dr. Mike Terabasi from Bay State Medical Center.
Dr. Masumi, I'd like to congratulate you on this excellent, thought-provoking presentation. I have 2 questions for you. The compensation for CPT codes you have selected includes a global period. the period of time for which procedures compensation is supposed to cover postoperative care. I'd like that you use length of stay along with operative time to try and put a measure to the time the surgeon has to invest in the care of the patient. In the NISQIP database, there are a number of other outcome measures that could add to your ability to measure the surgeon's investment in the care of the patient postoperatively, such as 30-day hospital readmission rate and a number of different postoperative complications. Do you consider using these outcome measures? How do you think these may impact your results? Do you think they would show a greater void between adult and pediatric specialties or make them appear more similar? Second question, the RVU compensation system does not just factor in time spent caring for the patient, but also the complexity of the thought process needed to care for the patient. For office consultations, there are 5 different levels of care that can be chosen depending on time spent or complexity of the thought process. For a surgical CPT code, there is only one level of care, with the option to petition for the 22 modifier, increased procedural services, which can increase the compensation by about 15%. In your study, were you able to take into account the use of the 22 modifier? Since in your study you identified disparities in both directions between adult and pediatric surgeons, do you think an expansion of the modifier system to provide for multiple levels of care for each CPT code might help balance the inequality you identified better than calling for the creation of a new list of CPT codes for pediatric surgeons?
Thank you very much for your questions. For the first question, for patients with a 90-day bundle, providers are asked to estimate the time and complexity of care involved for up to 90 days postoperatively. And the 2 main factors that drive greater than 80% of this are operative time and length of stay, which is why we focus on these 2 factors. It would certainly be interesting to look at readmissions, as this would add to the total length of stay in the 90-day period. But readmissions were so rare in the diseases we looked at that it's unlikely to have made a significant difference to our findings. Furthermore, NISQIP unfortunately does not have enough granularity to look at the reasons for the readmissions and how involved the surgeon was for it to accurately reflect surgeon work. A smaller and more granular study at a single or at a few institutions would probably be more suited to answer this question. And then for your second question, the current RVU evaluation assumes a certain number and level of postoperative visits, both in the hospital and in the clinic. It is certainly possible that the complexity of postoperative care for children and adults is different, but it is unclear from our data whether or not this would make differences larger or smaller. We did not take the 22 modifier into account, as this information is not included in NISQIP, and while the modifier is an interesting concept, we favor the creation of separate CPT codes entirely. Many of these operations are technically very different from one another, and as you mentioned, require such different thought processes that they are almost entirely separate operations. In our opinion, treating them as such with separate CPT codes would be the most appropriate, as it would avoid relying on billing practices and hoping that payers will pay physicians more for more complex cases. Instead, pediatric surgeons should be paid concordantly to the effort actually expended, rather than a vague average based on an adult patient. However, it would be interesting to see whether or not modifier 22 is used more frequently in adults than in children, and it would be additionally interesting to assess whether or not payers actually pay more for the modifier 22 more or less frequently in children versus adults. These could be interesting studies to perform in the future.
Thank you, Drs. Masumi and Tirabassi. Our next abstract in the session will be presented by Julia Metzger from NYU School of Medicine. Her presentation is entitled, "It's Time to Deconstruct Treatment Failure, a randomized controlled trial of non-operative management of uncomplicated pediatric appendicitis with antibiotics alone."
Thank you so much for the opportunity to present at APSA. I'll be discussing It's Time to Deconstruct Treatment Failure, an RCT of non-operative management of uncomplicated pediatric appendicitis with antibiotics alone. Non-operative management of acute uncomplicated appendicitis has been well studied. Prospective studies, meta-analyses, and systematic reviews have shown it to be safe and effective, and to have quality of life benefits when compared with surgical appendectomy, the traditionally favored definitive therapy. With antibiotic treatment, there's risk of recurrence and unresolved appendicitis, and the success rate at 1 year has been shown to range between 60 and 85%. The key question, therefore, for clinicians and parents alike is what drives treatment failure. Existing literature has limited generalizability due to the selection bias inherent in non-random treatment assignment. The goal of our study, therefore, was a prospective RCT to validate the antibiotics alone approach and further characterize treatment failure. Across about 3 years and 3 different hospital sites, of the 756 patients assessed, 245 were eligible based on inclusion criteria of being between 6 and 17 years old with the first episode of uncomplicated acute appendicitis, as defined by the clinical criteria here, and radiographic absence of perforation or abscess. 39 families, or 16%, enrolled. 19 were randomized to surgery and received laparoscopic appendectomy, 20 to antibiotics, receiving IV for the first 24 to 48 hours and transitioning to oral when certain clinical criteria were met. Outcome measures included the 1-year success rate of the antibiotics alone treatment, quality of life metrics assessed at 1 month, and the length of stay and readmission rate. Our outcomes were consistent with existing literature, with a longer length of stay and higher readmission rate for the antibiotics group. Among our quality of life metrics, we saw statistically significant differences with a faster return to normal activity for patients and fewer days of work missed by parents with the antibiotic group. Returning to our flowchart, 6 of the antibiotics cohort received surgery at some point, yielding a 70% success rate. The data were underpowered, unfortunately, to identify characteristics at admission or at 48 hours or discharge that could predict success or failure of antibiotic treatment, including the presence of an appendicolith. We were able to further characterize failure, however, showing that 2 were direct failures due to failure of antibiotics to treat the underlying disease, but 4 were due to indirect or pragmatic failures that were less clearly related to antibiotic efficacy. Let's take a closer look. In the 2 direct failures, antibiotic treatment was unable to address disease. We saw progression with 1 case of unresolved and recurrent despite compliance to therapy. The antibiotics failed and they failed early. In the 4 indirect or pragmatic failures, however, parental concern and anxiety about insurance and perceived pain despite an improving clinical picture drove 2 of the failures, and misdiagnoses drove the other 2. In 1 case, later review of initial imaging showed a perforated appendix which was mistakenly read as uncomplicated appendicitis. And then the other, the PATH report following surgery showed lymphoid hyperplasia, an under-recognized entity that can mimic appendicitis radiographically but is distinct. It's unclear whether this patient never had acute appendicitis or had an appendicitis that was successfully treated with antibiotics and then later developed a bout of lymphoid hyperplasia. Overall, 30% of the antibiotics cohort underwent surgery, but only 2 patients, or 10%, reflect true failure of antibiotics to address the underlying disease. In conclusion, we've demonstrated that failure of antibiotic treatment is heterogeneous and not always due to failure of antibiotics themselves. Some of the indirect failures, like radiographic accuracy, may be particularly relevant for sites such as ours, the children's hospital within adult hospital model of healthcare delivery, in contrast with the large freestanding pediatric hospitals. And we, as pediatric surgeons, need to educate families around the real-world experience of appendicitis treatment. Thank you to Sofia Perez-Otero, a medical student with whom I've collaborated closely, and to our incredibly supportive mentors, Dr. Tomita and Dr. Fisher, as well as Drs. Kensler, Ginsberg, Ramaraj, Choi, and Tashiro. Thank you.
Thank you, Ms. Metzger. The invited discussant for this paper is Dr. Paul Danielson from Johns Hopkins All Children's Hospital.
Ms. Metzger, I want to thank you for a wonderful abstract. I think you and your colleagues put together a great study. I just have a few quick questions for you. The first has to come with, the main outcome measure for your randomized controlled trial is sort of treatment of appendicitis, and you have a 70% success rate. I was wondering if you sort of did a statistical significant comparison to what would be the gold standard, which is a 100% success rate.
Given that the surgical treatment for early appendicitis is definitive, always 100% taking out the appendix, and very rarely aborting mid-surgery, it's sort of always 100% of a success rate, right? And so existing literature, a statistical comparison to that 100% benchmark isn't typically done, which is why, we sort of didn't include that in the abstract itself, but we did run a Fisher exact one-tailed comparison between that 70% metric of antibiotic success and the 100% with surgery. And the p-value was 0.48, which was not an inferior outcome. So hopefully that answers your question.
All right. So the other thing I wanted to ask is, in your study, the operative group had significantly shorter length of stay, a significantly lower rate of readmission, and a higher success rate. So I'm wondering, is there really equipoise to offering non-operative treatment purely due to the advantage which you showed was fewer parental missed work days? And in your metric of a faster return to normal activity, I kind of question because they all return to school at the same amount of time.
Yeah, I think that follows well from the first question and is also a good one, and relates to how we compared the two different groups. So our outcomes that we present are between the full surgical group and the full antibiotic treatment group. So both those that successfully were medically managed and those that failed the antibiotic therapy and ended up getting surgery. And so it sort of follows from that when comparing to the whole antibiotic group, which includes those failures, the length of stay was longer of, around 2 days compared to 1 day with the surgical group. Given that if the failure of the medical management occurred at that first admission, they were in the hospital longer, right? And then similarly, if there was a recurrence of the appendicitis or if it wasn't fully resolved over a longer period of time, they were returning to the hospital to have it fully managed, which would lead to the readmission rate with that return. And so given that it includes the failures, that sort of comparison and outcomes shows a difference. When you're looking at a likely successful management medically, we write about how those other quality of life metrics of parental return to work faster, and perhaps not, a return to school necessarily, but a return in the patient's reported feeling of health and well-being, that those matter more, or just do matter.
But my last question is, I'm fascinated about how you guys looked at drivers of failure. And I'm wondering though, if you look at this further, are there other determinants of healthcare access that may make this option not a great option? For example, patients that live in rural areas, or maybe some groups that have a cultural aversion to going to the hospital or going back to the hospital.
Our goal was to understand what is driving this failure. And we did that in, the constraints of our existing healthcare setting, and think that we were able within that setting to characterize some of the heterogeneity of these failures. And some of that is generalizable. So, some of our indirect failures were parental concern. Some of them were due to insurance problems, which, may or may not exist for certain populations in certain settings, more or less. And then also the degree of radiographic access and accuracy in reading those initial ultrasound or CAT scans of the abdomen. And something interesting is that, across our 3 sites, enrollment in the city hospital was actually the lowest, not from a lack of interest from patients and parents at all, but actually because of a lower eligibility. Most often those patients were presenting with more advanced and sometimes ruptured appendicitis, which was an exclusion criteria. And data does show that there are higher rates of perforated appendicitis in patients who have barriers to healthcare access. So sort of all of this to say, thank you. Yes, we do believe that social determinants of health drive this decision and drive outcomes as well. And we hope that this can contribute to the understanding of what those drivers of failures are in our healthcare setting, and hope it sparks additional research in other, you pointed out rural settings as well.
Well, thanks again for contributing this abstract to APSA. You and your colleagues did a great job.
Thank you so much for this great discussion.
Thank you, Ms. Metzger and Dr. Danielson.
Our final abstract in this session will be presented by Catherine He from Boston Children's Hospital. Her presentation is entitled Frequency and Fiscal Implications of Potentially Avoidable Surgical Referrals for Asymptomatic Umbilical Hernias in Children.
Thank you for the opportunity to present our work. Umbilical hernias are a common childhood condition. The majority resolve by 4 years of age, and incarceration is exceedingly rare. Rates of recurrence and complications have been shown to be higher in children undergoing repair at 3 years of age or younger compared to older children. Based on these considerations, as part of the Choosing Wisely campaign, the American Association of Pediatrics and its section on surgery recommends avoiding referral of asymptomatic umbilical hernias until age 4. Early referral may lead to lost caregiver productivity, unnecessary healthcare costs, and avoidable surgery to fix hernias that would otherwise resolve. To date, compliance with AAP guidelines by referring physicians has not been well characterized. The purpose of our study is to assess the rate of potentially avoidable referrals, describe indications for referral, and to evaluate disparities in referral patterns. We performed a retrospective review of umbilical hernia referrals to Boston Children's Hospital's surgery clinic over a 5.5-year period. We excluded children with recurrent hernias and those where surgical timing was influenced by the need to coordinate with other procedures. Regression analysis was used to assess the association between patient characteristics and early referrals. The study cohort was identified using billing data, and chart review was performed to capture referral indications, including non-resolution, enlargement, perceived discomfort, and history of incarceration. Disposition following the visit was also assessed and was characterized as follow-up as needed, a scheduled follow-up visit, or scheduled for surgery. Our main outcome was rate of potentially avoidable referrals based on AAP guidelines. This was defined as a referral for an asymptomatic, non-enlarging umbilical hernia in a child younger than 4 without a documented history of incarceration. 643 visits were included in analysis, with a mean age of 4.2 years. The study cohort was mostly female, white, and publicly insured. 47% of visits were in children younger than 4. This early referral cohort was more likely to be referred for enlargement and less likely to be referred for failure of spontaneous closure or perceived discomfort. Disposition also varied between age groups at time of referral. In the early referral cohort, children were 6.7 times more likely to be recommended to follow up as needed, and 14 times less likely to be scheduled for surgery. This figure illustrates disposition following the clinic visit by age group. The x-axis is the age of the child at evaluation, and the y-axis is the total number of referrals broken up into disposition categories. Potentially avoidable referrals are represented in the dark blue, which are concentrated in the first 3 bars to the left in children under 3 years of age. In aggregate, these visits comprise 33% of all umbilical hernia referrals and 71% of referrals in children younger than 4. The median charge associated with the potentially avoidable referral was $684, and cumulative charges associated with all potentially avoidable referrals during the study period were $144,000. Rates of potentially avoidable referrals did not vary significantly between gender, race, or insurance status. The results of this study should be taken in context of its limitations. This was a retrospective study and reflected results from a single children's hospital and a single geographic referral base. Our study may be underpowered to identify socioeconomic differences and disparities that may exist elsewhere. Despite these limitations, we can conclude that potentially avoidable referrals are both common and costly events. Further efforts should include development of collaborative partnerships between primary care providers and surgeons to align expectations surrounding referral indications and to reduce unnecessary referrals. Thank you again for the opportunity to present our work today.
Thank you, Dr. He. The invited discussant for this paper is Dr. Jonathan Kohler from UC Davis.
So Dr. He, thank you so much for that really interesting presentation. I think that it's a testament to you and your organization that you are looking at your behavior around umbilical hernia repairs and thinking critically about whether this is an important whether there are important changes to be made in the way that you guys are doing umbilical hernia repairs. The data that you cover from your center, it covers 5 years of data, and it does show that you've been fairly adherent to the guidelines over that period. The guidelines, though, are actually quite new. They came out in November of 2019. So were you able to identify any changes in surgeon behavior after the guidelines were released?
Thank you for your kind question. We should mention that over the timeline of the study period, we had already as a group decided that we wouldn't repair umbilical hernias prior to 4 years of age. This was based on our universal acceptance of the more liberal consensus guidelines from the ACS and APSA that you should wait until 4 years. In a faculty meeting, we established consensus based on, 1, agreement that spontaneous resolution was still possible at least through the 4th year of age, and 2, risk of emergency surgery was exceedingly low during this waiting period. There was no appreciable change, at least statistically, in the rate of compliance by surgeons in the group. It was quite high both before and after the guidelines were released. But what we didn't know, and what we felt like there could be tremendous opportunity, was in referral patterns. Although the Choosing Wisely guidelines are relatively new, we felt that the same considerations for holding off on repair could be applicable to holding off on referral. We did look at the trend of potentially avoidable referrals over time, and there was no difference in rates of referral before or after the guidelines were released, about 35% before and 28% after. It's likely that the penetration of these guidelines remains limited due to a culture of referral, and efforts are really needed to align expectations surrounding referral and repair between primary care providers and surgeons.
Yeah, I think that's a huge point, right? Like it's all well and good to put it on the website, but people have to read it and internalize it and change their practice in response.
Exactly.
Have you done any qualitative work with your surgeons to try to understand when they would take patients to the operating room outside of the guidelines?
That's an excellent question. As the obvious next steps are, how do we move forward from this to reduce both avoidable referrals and reduce operations in children with hernias that would otherwise spontaneously resolve? When we analyze our own surgeons' practices to see how many of these avoidable referrals resulted in an operation, we found that out of the 228 patients presenting at age 3 years or younger with an asymptomatic umbilical hernia, only 3 underwent repair, reflecting about a 99% guideline compliance rate. We did do a deeper dive of these 3 cases and found that size, family history, and proboscoid morphology were motivations for early repair. However, we were limited by the retrospective chart review and fully understanding the nuances of decision-making in these cases, which on the surface appear to be non-compliant with the guidelines. This was a limitation of our study. In response to these data, we will begin to prospectively monitor repair of cases before 4 years of age in clinic, with audits of repair indications within 24 hours of the procedure.
Fantastic. Yeah, I think that, I mean, that gets to some degree to this question of, you know, surgery remaining an art, right? We are not just technicians. And I think there probably is a role for surgeons to be involved in discussions about non-operative management and in reassurance, right? So do you think it's truly a waste if a patient comes to clinic only to be told they don't need an operation?
This is a really important question. I thank you for asking it, because there are definitely patients who may not need an operation that would benefit from the expertise and perspective of the surgeon. Parental anxiety is a phenomenon that cannot be discounted when it comes to conversations with caregivers regarding surgical decision-making. Our survey of APSA members demonstrated that parental anxiety over risk of incarceration, concern over perceived parental neglect by peers, and cosmetic appearance all influence a surgeon's decision to operate early. In the end, the question is, does a caregiver need a surgeon to personally tell them that surgery is not necessary, in addition to a trusted primary care provider? Given the tremendous public health costs, we believe the answer in the vast majority of cases is no, although there are likely to be cases where surgical expertise makes sense. These may be cases with particularly large defects, a strong family history of a repair or incarceration, and cases where repair is being considered in combination with another procedure that requires general anesthesia. These are the gray area cases where we as surgeons do not know the right answer, and where an informed discussion between family and surgeon could be quite valuable. However, from a public health and healthcare resource perspective, we think it's incumbent on surgeons and providers to partner in reducing the number of referrals for truly asymptomatic garden variety umbilical hernias.
Fantastic. I think there's real value in navel gazing is what I'm taking away from your excellent work. So thank you so much.
Thank you so much for your time.
Thank you, Dr. Kohler.
This concludes our APSA scientific session number 2. We thank you for watching, and thank you to all our presenters and invited discussants. Have a good evening.